Great. So I thought I'd present something that's slightly different to what we usually are used to here. And this is actually a paper from China that has been published in JCEM in April this year, which is looking at the effectiveness and safety of thermal ablation in the treatment of primary hyperparathyroidism, a multi-center study. So just as a brief background, because I won't rehash everything about primary hyperparathyroidism, but at the moment, when we're thinking of treatment options, if they fulfill the new NICE criteria for surgical intervention, we would ideally like to refer them for surgery and definitive management in the form of minimally invasive parathyroidectomy. And that's what we'd recommend. For patients who don't desire surgery or where surgery is not appropriate due to medical comorbidities, then cinacalcet would be our medical management of choice. This is also the case in patients with secondary or tertiary hyperparathyroidism related to renal disease as well. Although some of these patients will go on to have 3-gland parathyroidectomies as well if their parathyroid hormone secretion is extremely problematic, or they have bone disease related to the hyperparathyroidism. So it seems like over the last 5 to 10 years, there's been a new treatment that's been used, particularly in China, but there's a few papers from Turkey as well, where they're looking at a new way of treating primary hyperparathyroidism, which is ultrasound-guided thermal ablation. So that comes in 3 different forms. So there's the radiofrequency ablation, microwave ablation, and laser ablation. So the technique for each of them is largely identical. It's just the method of ablating is slightly different. So as you can see from here, it's done with a patient in a supine position, and it's actually done with just through a small incision. And then the ablative rods are inserted through the small incision under ultrasound guidance, which I'll go on to on another slide. So there aren't very many studies actually directly comparing surgical resection, which is our gold standard, versus the thermal ablation. But there was a study published in 2019 in the International Journal of Hyperthermia, again from a group in China, which was an observational retrospective study over a course of 5 years, where they compared 28 patients who underwent surgical resection and 28 patients who had the microwave ablation, and actually found that there wasn't really a significant difference in the cure rate, or a statistically significant difference in the cure rate, with 89% of patients being cured with surgical resection and 82.9% being cured with microwave ablation. I think that was looked at a 6-month follow-up. They found that actually the cure rate in surgical resection in this study was actually lower than what's widely quoted by a lot of centers who are undergoing parathyroid surgery, where the cure rate is more often quoted to be around 95%. So the benefits that they found of the thermal ablation over the surgical resection is reduced blood loss and a shorter surgical time. And the short-term results were thought to be comparable in the sense of monitoring their biochemistry in terms of the parathyroid hormone levels, the calcium, and phosphate within a 6-month period. So actually there was an equivalent normalization using both the microwave ablation and the surgical resection. Now, one of the drawbacks that's been flagged up quite a lot in the studies with thermal ablation is the fact that it's often performed with contrast-enhanced ultrasound in order to guide the target for ablation. However, the recurrent laryngeal nerve is not often visible on this ultrasound. So one of the common adverse effects of the thermal ablation is heat damage or accidental ablation of the recurrent laryngeal nerve. So even in this study of the 56 patients, 2 of the patients with the thermal ablation had transient hoarseness of the voice after the ablation, compared to none with surgical resection. So there was a meta-analysis published last year in the same journal, which actually found there were about 186 papers, but they only actually picked out these 5 studies. So 4 retrospective studies and 1 prospective study looking at the efficacy of thermal ablation in treating primary hyperparathyroidism, and found that of the 84 patients, there was a significant reduction in PTH and calcium at 3 and 6 months after thermal ablation. And again, it echoed the fact that the most common complications seen are transient dysphonia due to heat damage to the recurrent laryngeal nerve and subcutaneous edema. And they'd actually stipulated that obviously the studies that have been done so far are quite short duration, small numbers of patients, largely retrospective. So they couldn't conclusively recommend that this would be a viable alternative to to surgery. But looking at the number of patients who are actually going ahead and doing it, and it's retrospective, it seems to be that it is an accepted practice in China to actually use the microwave ablation for primary hyperparathyroidism, where patients are not deemed fit for surgery.
So in the 84, what they all were better? All 84 were better.
Yeah. So that was from the data, from all the studies that they picked out. They found that I think it was 87% of patients were not 100%. No. And the failure of ablation takes multiple different forms in the sense of persistent primary hyperparathyroidism or recurrence within 6 months.
And Manish, did any of them have permanent nerve damage using this technique?
No, so most of the patients resolved within 3 months. In the study that I'm going to suggest, there was one patient who did have persistent after 6 months. So nothing from these meta-analyses and previous studies that have been done.
Because that's a good point, because you'd think that this is much safer than surgery, which is obviously they might accidentally damage the recurrent laryngeal.
Yeah.
So this is also a bit damaging then.
Yeah, so it's definitely not completely risk-free, and I think that's one of the main anxieties, is that the recurrent laryngeal nerve can't be visualized, and so then you don't know until they have transient hoarseness that you've actually pinged something. Whereas in surgery, you can try to avoid or move aside and not ping it. So the aims of the current study is, given the fact that the previous studies are quite small in size, retrospective, and quite short follow-up duration, so the maximum duration in those 5 studies was only 6 months. They aimed to assess the effectiveness and safety of thermal ablation for primary hyperparathyroidism, and in a larger cohort of patients from 4 different centers, and using a longer term follow-up. So the median follow-up in this study was 18 months, but some patients were followed up for as long as 40 months.
So is this a radiofrequency or microwave?
So this, the study that I'm going to present is a combination. So there's patients who've had both.
And in both of them, the needle goes through the skin too.
Yeah, so both of them go through this.
They're not non-invasive, they're both invasive.
No, they're both invasive. So it's a ½ centimeter incision. The position will depend on which part of the gland they need to access, but they're usually supine and there is an incision. So it's compared.
Not selling to people like there's no incision. There is no. If it sounds like people, they will still suffer.
Yeah. So the study design was, it was a retrospective analysis between January 2015 and March 2020, where they identified 306 patients with primary hyperparathyroidism, and 119 of these patients had actually undergone thermal ablation at 4 different centers. So 96 of these were microwave ablations and 23 of these were radiofrequency ablations. Of those patients, there were a total of 134 parathyroid nodules. So some of the patients did have multiple nodules, all which were treated during the ablation.
And
as well.
Did the other half have surgery?
Yeah.
So they compare the surgical ones with,
So in terms of the selection criteria for the patient, so as I mentioned, there's 306 who were diagnosed with primary hyperparathyroidism. Some were excluded based on the fact that they had recurrent disease or they'd had a parathyroidectomy in the past. And then these were whittled down to patients who were symptomatic of hypercalcemia or who were asymptomatic and had failed medical therapy or had ineffective medical therapy. So the patients who were effective with medical therapy were also excluded from this 306. So this wasn't compared to surgery. It was just ablation or medical therapy. It wasn't patients who were deemed to be fit for surgery. So this number whittles down a bit further on the next flow chart as well.
So medical therapy means
cinecalcin. Calcium mimetic and fluids, and that's about it. And vitamin D replacement. As well.
No one got bisphosphonates or.
So the ineffectiveness of medical therapy was judged by a T-score less than -2.5, fragility fractures, an age less than 50, a low creatinine clearance or reduced creatinine clearance, or development of renal stones, or a calcium above 0.25 millimoles per litre above the normal upper limit.
Okay, so those are the indicators for surgery. So if they go on the right-hand side, effectiveness, I don't know what's behind that thing, but...
oh yeah, I think it's got a number. So 48 of them had didn't meet this criteria with medical intervention.
They didn't have a bone problem and they were not the wrong age.
So the effectiveness means?
So I think the fact that they didn't develop any of these features while on medical therapy. So if their calcium came down, they didn't develop osteoporosis, they didn't develop renal stones, and they were older. So those patients were classed as effective. There's not really, they don't really probe into that much more in this paper.
They
Because
will with time. I mean, it's the
They will.
at that time point.
Yeah.
Time. It's
Yeah. I mean, basically, at this point, they didn't fulfill the criteria to have an operation.
Yeah. So based on the index 306 that they identified as having primary hyperparathyroidism. Again, it's all retrospective, so they haven't really elaborated much more on the effectiveness in the other arms. So the patients who ended up having confirmed primary hyperparathyroidism, they had to have an ultrasound exam, which confirmed enlarged glands, and a nuclear medicine scan, which correlated with adenoma and increased uptake. So of those patients, there were 216 left, and 77 of those patients did end up going ahead for surgical resection. So those were excluded from the initial 306. And so the remaining 139 were the ones who'd either declined surgery or were ineligible for surgery. So the features that they used were what were deemed to be high-risk parathyroid adenomas, which they thought may be concerned for parathyroid malignancy, patients with severely deranged clotting or with significant cardiovascular. They excluded those patients. So that's what this box, this coagulation function test, concurrent disease correction, were excluded from that. So there were only 3 patients who were unsuitable, and then another 5 excluded, refused ablation. So in total, 131 underwent ablation and 119 were followed up. And I think the loss to follow-up would have been within 6 months. So the minimum follow-up requirement was 6 months to be included in this study. So we went on to 119 patients, and in the retrospective design, they looked at serial parathyroid, calcium, phosphate, and alkaline phosphatase levels. So 24 hours before ablation, 2 hours, 1 day, 7 days, 1 month, 3 months, 6 months, and then 6 monthly intervals. As I mentioned before, so the median interval of follow-up was 18 months, but there were patients who were followed up for as long as 40 months as well. So the primary outcome they defined as cure, which was a normal serum calcium and parathyroid hormone level throughout the follow-up period and at least 6 months after the ablation. And the secondary outcome was the rate of complications. So persistent primary hyperparathyroidism was defined as an inability to suppress their calcium or parathyroid hormone within the 6 months after the ablation, and recurrent primary hyperparathyroidism was thought to be a rise after the 6 months. So initial resolution and then a rise after the 6 months. So these are the baseline characteristics. So as you'd expect, predominantly females in their 50s. A proportion of them were symptomatic and asymptomatic, so you can see it's nearly an even split. So the average parathyroid hormone level in these patients was around 15 picomoles per liter. So they've got 145 here, with a calcium level of 2.7. Interestingly, well, as expected, probably a lot of the patients were vitamin D deficient during this. So a lot of them were started on vitamin D replacement prior to ablation, but it didn't seem like everyone was made vitamin D replete prior to going ahead. But everyone was started on 2,000 units once a day. So this is just a figure that I've taken from the paper, which just shows the kind of sequence of what actually takes place. So they have
Manish, sorry to interrupt. Just going back, did they use the cutoff of 10 millimoles of urine for 24 hours, calcium in the urine, as a indication for treatment, for surgery, well, ablation?
From what I remember, I don't think they didn't specifically mention that's how they had diagnosed them, but that was their clinical diagnosis. But there wasn't a specific mention of urine, as far as I remember. I'd have to recheck.
Yeah, no, because that is the other indication for surgery in asymptomatic hyperparathyroidism is a urinary calcium greater than 10. In addition to that list you showed before, which are the list of indications.
It wasn't in the.
Is that a 24-hour?
In 24 hours, yes. So urinary calcium over 10 is an indication for surgery in an asymptomatic patient. That together, that or a kidney stone, in terms of the kidney complications, or an EGFR less than 60, or creatine clearance less than 60. So there's 3 things that kidney-wise you would go for surgery, and then there's the bone things, which are a fracture or a minus 2.5 anywhere.
They have to exclude FHH. Is that mentioned at all?
No, there's no mention of FHH.
Alex, can you hear me?
Yes.
I think the point is that the calcium greater than 10 changed over time. So the international guidelines used it to start with, and then it was taken out of the international guidelines because it was felt not to be fully predictive, and then it came back in again. So depending on the timing of your retrospective study, that would not have been a criteria for surgery during a certain time period. So I think that might be why, but it's a good question. But yeah, it was probably unfortunately at an era when they'd gone against it for a while. I think 2012 to 2000.
So the way I remember is A, B, C, D. So H, there's the A, B, bone, C, calcium, calculi, creatine clearance, and D, difficult to follow up. A, B, C, D, your criteria.
So back to the figure. So they, as I mentioned before, they need to have a nuclear medicine scan, which showed increased uptake, followed by an ultrasound and a contrast enhanced ultrasound, which shows increased uptake over the adenoma. So the white arrows show where the adenoma is, the yellow arrow is the internal carotid artery. And what they do is basically they use something called hydrodissection. So 30 to 40 mils of normal saline is injected around the parathyroid gland to separate it from the surrounding organs.
Under ultrasound guidance.
Under ultrasound guidance.
Okay.
So the adenoma is identified, then the incision's made with local anesthetic. And that's the other difference with the parathyroidectomy as well. So using local anesthetic and identifying the adenoma, and then using a large needle to actually put some normal saline around the lesion to separate it from surrounding structures so that the parathyroid gland is isolated. And then a continuous infusion of normal saline is used to keep the surrounding tissues cool as well, to prevent any thermal damage for when the ablation rod is actually inserted. And then following ablation, there's another contrast ultrasound, which you can see that actually the enhancement disappears, and that's how they know that they've effectively ablated a certain area.
So the contrast is injected IV.
Yeah.
And it's taken. So what contrast is it?
Oh no, actually, I'm not sure. 100%, sorry.
What is it being taken up by the parathyroid? It's being washed away now.
That's a good point. I don't know.
Well, what do you mean? You mean
What's the
As in what's
size?
coming up, what's actually coming up on
What's
the...
coming? What is it that you inject that's taken up by the adenoma?
on the system maybe?
It's on the
No,
top
on the
right.
contrast enhanced ultrasound.
It's not. It's a contrast enhanced ultrasound. So what is it? This ultrasound
Is
showing?
that not microbubbles?
But is microbubbles being taken up by an adenoma, not by the
Well,
surrounding?
I don't know if the adeno is taking it over. That's what they mean by contrast ultrasound. It's air, isn't it? That's the only thing I've heard of is being contrast enhanced ultrasound.
Yeah, if in the heart, if you got a hole, you inject microbubbles and then you get the process, but they
No,
haven't
it is
injected anything into the adenoma.
No, they haven't injected into the adenoma. I'll have a look at the methods. They have actually mentioned a bit more detail about the contrast. I tried to avoid too much excessive detail about
Thank you.
the modalities. So this is just a brief schematic just to show what hydrodissection actually is. So you can see, depending on where the adenoma is, the fluid actually then creates a buffer between where the adenoma is and any structures that you want to avoid damage to. But obviously a lot of this, like for example, the recurrent laryngeal nerve, you're assuming that that's the buffer that you're creating and that you won't be hitting the nerve, but you can't actually see that on the ultrasound. And the main structures you're worried about are the esophagus, the trachea, the carotid artery, and the recurrent laryngeal nerve. So the results of the study, so that they found that the technical success rate, which I think they just meant as they managed to successfully ablate the target that they were aiming for, whether that was a parathyroid or not, was 98.3%.
Yeah, blame these softwares.
So the cure rate was quoted as 89.9%. So 107 of the 119 patients had a normalization of their parathyroid hormone and their calcium at 6 months. And that persisted to 82.3% by 18 months. 12 of the 119 had actually failed by the criteria of the 9 being persistent. So they didn't actually achieve suppression of the parathyroid hormone or the calcium within the 6-month period. And they did note that 7 of those didn't actually have ablation of an affected nodule. So 2 or 3 of them had ablation of a reactive lymph node. And the others were just adjacent soft tissue, which they thought was an adenoma, but it didn't end up being an adenoma.
So it was definitely something else was ablated.
Something else was ablated in 7 of those cases. Okay. 2 of them were just persistent. following ablation, successful ablation.
Okay.
And 3 of them had recurrence, so a rise in their parathyroid hormone and their calcium after 6 months, but none of those 3 had new adenomas. So it was just the same adenoma which hadn't been successfully treated. And for the comparison between the microwave ablations and the radiofrequency ablations, it was at 6 months. They only looked at 6 months, and there wasn't a significant difference between the 2, despite a large proportion of them being microwave ablations anyway. So there's just a graph just showing the drop in parathyroid hormone. You can see within 2 hours, there was a massive drop in the parathyroid hormone level, which was then persistent for up to 14 months in the patients who achieved cure, if they were followed up for that long. But like I said, median was 18. The calcium level was also seen to fall. And then the ALP was seen to have an initial spike and then a fall as well. That just confirms what they were defining as cure in follow-up as well.
And the phosphate is which line?
The phosphate's this one. So there's a slight rise in the phosphate,
Okay.
and then it just plateaus out. So they also use a formula to calculate the volume of the ablated region, and they found that actually at 12 months, there was a near 100% reduction in the size of the nodule after ablation, but you can actually start to see a significant difference at 3 to 6 months. So it seems like it's a persisting effect after it's been ablated.
It slowly shrinks.
Yeah.
Okay. So what's the, just go back one? What's that unit in days? Is it called?
Months.
At the bottom?
Months.
So 12 months.
So at 12.
So it slowly shrinks, but you don't get you get a decrease in cure rate with time. So you either get it right first time, early on, as it were. It's not a long. It's not like radiation therapy or something. Which
No, it won't continue to have a long-term effect. And if you're going to achieve it, you're going to achieve it quite early.
So the calcium falls very quickly, and then the size of it follows. Yeah.
Yeah.
It goes down immediately, like one day. Yeah. That's
Yes, the calcium falls in 1 day. The parathyroid hormone drops within 2 hours. But then the size of the lesion.
It shrinks slowly subsequently. Over 3 months.
So go back to the phosphate.
So the phosphate
Goes up a bit.
goes up after 7, or slowly up to 7 days, and then plateaus out. So the complication rates, which is probably what people are quite interested in as well, compared to surgery as well. But they're not directly compared here. But the main complications, as I mentioned before, were hoarseness of voice due to some heat damage to the recurrent laryngeal nerve. So 6 patients did have hoarseness of voice, and one of these patients did have persisting hoarseness of voice for the duration of their follow-up as well. 2 patients had localized hematomas following the ablation, which all spontaneously resolved as well. And then other very infrequent side effects were fever, headache, and hypocalcemia. Something I didn't quite look into, but there was a reasonable proportion of patients with hand numbness, and then transient hyperparathyroidism as well. But all of these side effects were thought to rapidly improve within 1 month without any specific therapy. So really the only persisting complication in this was the persisting hoarseness of voice.
Was the hand numbness on the same side? It's interesting, isn't it?
They didn't elaborate on that, but I didn't get a chance to look into that. But it was a bit unusual that they get hand numbness following an ablation.
That's related to the hypocalcemia, isn't it?
But it's unusual because only 2 of the patients had unless we're thinking about relative hypocalcemia, but only 2 of the patients actually exhibited hypocalcemia. So it's interesting that they develop hand numbness.
It depends how they define transient hypoparathyroidism, because transient hypoparathyroidism should be hypocalcemia with a low PTH.
Yeah.
Jeremy would have a better feel for it, maybe.
I mean, it might be that when you remove the one adenoma, the other 3 are still a bit of steam, and then they recover after you have a bit of hypocalcemia. But it's just the word numbness. I wonder what they mean.
18 out of 18 is a lot.
Well,
That's what it's a significant.
Hypocalcemia, it's transient hypocalcemia tingling, isn't it?
Yeah. But it might be sort of what we would call numbness and tingling, perhaps.
Yeah.
But you get carpopedal spasm.
No, that is really,
Paresthesia perioral rather than in the hand.
Yes.
Jeremy, have you seen anyone with hand numbness from hypocalcemia?
Yeah, they do complain of it, and we don't think of it as a very hard sign because it's so easy to block off venous return in the arm or to sit on a nerve.
Yeah.
So that's why we don't tend to use it. But they do complain of it, yeah. So I think it's an allowable feature. It's just it's so positional.
But if you
And
lie
it's
on
so common at night in normal people.
in theatre.
Yeah.
Yeah. Okay.
Thank you.
Can I say what worries me here is that sometimes we'd have to get Fausto in, but your recurrent laryngeal nerve is often plastered onto the adenoma and runs actually on the adenoma and is quite difficult to dissect off very carefully. So this sort of whole idea that you can create an effective fluid plane is interesting. There's clearly going to be a number of cases where that simply isn't going to happen.
Yeah.
So you cannot but damage the recurrent laryngeal nerve.
Well, it might be that this is a technique that Fausto might use intraoperatively. If it actually can inject saline in between the nerve and the adenoma, it's not something I've ever heard of before.
No, I agree.
But I'd like to be an open mind. But yes, you're right. We should see what Fausto thinks. Yeah.
I'm sorry to do, but we did have Amy in here just a few minutes ago, but she's just left. So
Right.
Unfortunate.
Okay.
So from their discussion in the paper, so they have quoted that they do accept that the ablation does have a lower cure rate than surgery, both from that paper in 2019 and also compared to what most centers are quoting as their success rate with parathyroidectomy of above 90%. And they attributed a lot of the false, or the failure of cure to false puncture or incomplete ablation. So they actually looked at the size of the nodules as well, and they found that if they excluded nodules that were less than 0.6 centimeters, so quite the smaller nodules, then actually the cure rate was up to 95%. So they possibly thought that these procedures do need to take place in centers that are experienced, but it could just be that some of these smaller nodules are quite hard to target. And one of the reasons is the hydrodissection. So when the fluid is injected in, some of the smaller lesions can look quite similar to the surrounding liquid on the ultrasound. So actually it's a case of it's quite easy to not ablate the right section because you actually end up ablating a part where you just see the fluid as hypoechoic rather than the nodule itself. And actually 7 of the 9 patients who had nodules less than 0.6 centimeters, 7 of those weren't cured, suggesting that it was the wrong bit that was ablated. The recovery time is thought to be shorter than surgery. So it's normally 3 to 5 days post-ablation, because as we mentioned, it is still an invasive procedure. So there is still that recovery time. And the quoted time is 9 days post-surgical resection, which seemed a bit long quoted for them, but I don't know if that's actually how long we're keeping patients in after that. 9 days, I don't think so. That's what they've quoted. I don't think that seems like a massive overestimate. Yeah. And they've identified that the key factor to achieving a cure is mastery of the puncture techniques. So
how long do they stay? So pastors and parathyroidectomy?
They definitely don't stay for 9 days. No, that's what's been quoted in this study. I don't think that's.
How long do they stay?
A day.
A day or so.
They go the next day, and then we can calcium measurements the day after that at home sometimes. We get the patient that's very quickly done, and they have any PTA, so they know what.
So that means that last one might not be much of a selling point for ablation if we're getting people out the next day. Yeah. So then the key factors were mastery of the technique, complete ablation, as we'd expect, and adequate vitamin D supplementation. Because I mentioned that the three of the patients who didn't successfully weren't successfully ablated and had a reasonable sized nodule had vitamin D levels less than 30. But they haven't quite elaborated any more on that, why I think that would be relevant in terms of the ablation. And they accepted their limitations, which is they've said the selection bias because it's a retrospective study. And there isn't really a large study comparing thermal ablation and surgery directly. But I don't think that's necessarily a massive factor, because I don't think we're trying to replace surgery with microwave ablation. It's more that we're trying to see if there's an alternative treatment modality for patients who are not fit for surgery.
Yeah.
So while a comparison will be helpful, it probably still is going to go in the favor of surgery, given the technical difficulty and the limitations and the risk of complications associated with ablation. This study was mostly focused on the microwave ablation, although there were 30 patients with radiofrequency ablation as well. So we can't really tease out if there's any differences between the two. And also, because they were only quoting up to 6 months comparing the two, there's not really an in-depth analysis of longer term, is there any real difference between microwave ablation and radiofrequency ablation? And ultimately, I think, as we were saying, is that if they've not had we're not going to get histology from these patients. So we're ablating a gland and we don't have a pathological diagnosis that we have taken out an adenoma. And we're relying on the parathyroid hormone and the calcium normalizing as a surrogate marker of cure and diagnosis, really. So they've concluded that thermal ablation was an effective and safe treatment, and that the microwave ablation and the RFA had comparable medium-term results, but that this may be more relevant to nodules that are larger than 0.6 centimeters because they can't reliably cure and treat them, or based on this study, if they're smaller than that, just because of the risk of ablating some adjacent tissue. So it seems to be a string of these studies seem to have come out in the last year. So it wasn't just this one random paper. So there's two of these groups from China. One is from Turkey, where they have actually quoted quite similar success rates. But again, these are 6 and 12-month studies where they've quoted success as normalization of PTH and calcium. But they are quite consistent. So it's not that they're quoting very variable results. There's also some interesting studies, I think, which predate the use in primary hyperparathyroidism, which is actually looking at ablating glands in secondary hyperparathyroidism to reduce the burden of the hyperparathyroidism, but the cure rates in that in dialysis patients, but the cure rate in those seems to be much lower, around 60%. And there's
it's a mixture of radiofrequency and microwave, different ones. The one you were describing was radiofrequency.
So it's both.
so the technique is the same. It's just what the rod that they use and the modality of actually ablating. So they can use radiofrequency or microwave. But the study that I showed was 90 of the patients were microwave and 30 were radiofrequency. But they said there were comparable results at 6 months between the two.
So the radiofrequency get higher current passing through the needle than ablating. The microwave get much less emitted from the end of the needle course. Can I ask you, what's the fastest goes general anesthetic, correct? So the advantage here is local anesthetic for somebody who doesn't want to have
Was it under local?
Yeah,
this is local.
ablation's under local. Yeah.
Whereas fast is not, but he does, although you can do local, he does general.
Always is general.
So this one advantage here is just the local, because the rest of it, there is still a scar here.
Yeah.
There's risk of recurrent laryngeal. What's the recurrent laryngeal nerve? Risk with surgery? In that, they didn't have a comparison.
No. The paper that I looked at doesn't actually mention, apart from saying we haven't compared surgery, they've not really mentioned any breaks about surgery or quoted.
I mean, so we don't know it exists, but whether we'll take it on, I don't know.
So about 4 or 5 years ago in the December meeting, I did exactly the same talk on thyroid nodules. What's happened since? Has anyone used radiofrequency microwave here?
Not here, but
Because it was a new technique, you know,
Yeah.
knew what's on the
they've
right.
talked about it in a UCL, but they've stopped doing it. So it's not happening.
So I guess the question is, in what patient might we consider this technique? Might we consider it in a patient who it wouldn't tolerate a general anesthetic and has a difficult to dissect neck? Because otherwise, Dimitri and Amy can both do local approaches as in local anesthetic, minimally invasive surgery. So why would you want to go to the microwave? I guess would be only if they've had previous neck operations and it would be very difficult to get out the adenoma.
You also need somebody who's highly skilled doing this. Do we have?
No, the other problem is if they've had previous neck surgery, this is not a goer because you won't be able to identify the adenoma accurately. You need to know what you're doing.
Yeah.
It would be for someone who is difficult to control or medical therapy, so for whatever reason.
Calcium over
Is it
3,
going down the surgical pathway?
not fit for anesthetic.
No, but you can do a surgical removal on the local. That's my point. So why would you do a microwave when you can do a surgical?
Well, 1 or 2 patients who maybe had massive strokes and are bed bound in a nursing home who've never gone for the surgery.
So other conservative will see the calcium.
Well, it's a problem. I mean, I've got one patient who's on denosumab to try and control the calcium. So you might say that would be a really non-invasive, good to attempt.
You could do it on a patient who's got clotting, who's on a NOAC or something, or on warfarin, I guess, might be a safer option.
But they excluded them.
Yes, they excluded them.
Yeah, they excluded
could
those
put-
coagulopathy
they could
patients. Yeah.
puncture them because of the risk of bleeding, so it's not safer really.
Can I ask a question, which is on the ultrasound guided radio frequency ablation, does that need so much intervention? Do you need an incision like they've used for the thermal ablation?
From what I've read, I think it suggests they always do have to make the incision because they always have to insert the rod, and so it's completely guided to the parathyroid adenoma itself.
So
All the ones I've seen, they do actually have to make it. I think it's a 0.5 centimeter incision, but it was mentioned in all of the studies with radio and micro.
Because there has been some interest, Manish, in the department about doing, as Annie has mentioned, radio frequency ablation of thyroid nodules, and I think that gets quite a lot of interest. And if people are going to be doing that, then they might consider, the same radiologists might consider including parathyroids in a few patients. But as Alex says, if you've actually got surgeons who will do a local anaesthetic approach, and there's very few. I mean, we've done people with pulmonary fibrosis, etc., and we do it with them awake, and takes a little bit longer, up to about an hour, but it's still pretty good. So it's only a patient who cannot keep still, and I'm not sure this would even be particularly easy in a patient who couldn't keep still. So I think we're just fortunate here in that we have better surgical skill than most places, and so that actually the likelihood that one comes into the circumstances of needing this is fairly small. I don't know. I don't know what you feel. There's very few people who I've ever really. I don't know how the rest of you feel. Who I've said, okay, we know where the gland is, but we can't do an operative approach. Really, very few people.
I agree.
Come across that.
I know the one that
I
Emma
can
talked
think
about.
of one patient.
I can think of the same patient.
Who's in a neuro rehab centre for life,
Yes.
who had a hypertensive hemorrhage and has high calcium with a known parathyroid adenoma. It's not well controlled.
That would be a good one. Yeah.
And she's on cinecalcium,
She's on both.
It doesn't seem.
Can she keep still?
Not really. Not really. She's in that wheelchair, in that horrible.
No,
Yeah.
I think she gets very agitated.
That's
She
the
couldn't
problem.
lie down. And,
No.
no. Okay.
She's a neuro rehab type situation, but not really rehab. You know what I mean? She's just being cared
It just
for.
doesn't make sense to.
I guess if it's a shorter operation for the radio frequency, if it's significantly shorter than a local approach, then it may have an advantage there, especially for this patient, Emma's patient.
Same technique as was done on those couple of readers.
Yeah.
Yes. Radio frequency of the cons.
It is the same. It is the same.
What happened to the man with this
I think that's UCR.
APA?
But the patient.
The RFA, yeah.
Okay, so the cons have been cured.
That worked.
Yeah, that worked. It worked very well.
The cushion is less.
The Cushing, it hasn't worked.